I am Dr. Naif Aswani. I am the course organizer for the ophthalmology course. I would like first to welcome you to the ophthalmology course. First of all, we'll talk about the first thing that always students ask about is the grade distribution of the course. We know that the course is supposed to be 3 weeks, but because of the change in the yearly schedule, it become now 2 weeks only. The grade distributions will be, the midterm will be 30%. The continuous evaluation will be 10%. Final exam will be 60%, including MCQs and OSCE. Regarding the continuous evaluation, it will include the quizzes that will put it in blackboard, attendance, and also the spot diagnosis in the midterm exam. Any question regarding this slide about the grade distributions, you can ask, please. Already the schedule in the blackboard, you can check that the schedule include lectures, and we have also clinic visit, and there is also time for STL, self-directed learning. This is a very important questions. From where to study? We can study from the lectures mainly. Most of the questions, MCQs, and also OSCE exam will come from the lectures. Also, we'll put some information and quiz in the blackboard. And also, if you attend the clinic, it's very important to write notes, because sometimes there's some clinical instruments and clinical information you can take it only from the clinic. So be sure that during the clinic visit to attend and also to write notes. We have also the textbooks. We have Kaniski, Clinical Ophthalmology. It's a very famous book of ophthalmology. It has a lot of information and a lot of pictures. You can also take information from that. But as I mentioned, most of the questions come from the lectures. The previous slides was about the course of the ophthalmology. Now we'll talk about the ophthalmology program. Who is interested in ophthalmology program to attend, to join the ophthalmology after the graduation. Ophthalmology program in general, it has a 4 years training program. It's a very well structured program. We have many training centers. In Riyadh, we have multiple training center. We have in King Khalid Eye Specialist Hospital. We have in University Hospital, also Security Force. Also, we have in the National Guard Hospital, and also other hospitals in Riyadh. Jeddah and Dammam also we have, Abha Medina. Also, next years or next years, the Qasim will also start the ophthalmology program. So it's dependent on the person, if I want to be a surgeon or non-surgeon. Then you can decide which branch or program you want to join. In ophthalmology, you have a lot of subspecialty, mainly anterior segment, glaucoma, pediatric, retina. Retina, we have two. We have surgical retina, oculoplasty, neuroophthalmology, uveitis, and comprehensive. And we can also become a general ophthalmologist after finishing the residency program. During the programs, the same other training program, you will have clinic, surgery, and also you have in course. So we are talk about the ophthalmology, not only cataract, because it's famous that in ophthalmology we have cataract. Cataract, I mean that الماء الأبيض. Cataract is only a small part of the ophthalmology. Sometime you will notice, or you will also have a picture like this after trauma or something. Sometime will be not easy thing to manage. So this is about the training program of the ophthalmology. If you have any question, you're welcome to ask about the training program of ophthalmology. Any questions? We'll go now to the next part, which is the anatomy review. This is a picture of the gross section of the eye. We can see here, this one is the lacrimal gland. This is the nasal part to the right, and to the left is the lateral part. We can see the lacrimal gland here. These are the duct of the lacrimal gland. This one is called lid. We have upper lid and we have lower lid. Also nasally, we have the lacrimal sac and lacrimal canal with punctum. So this is the lacrimal system. We have lacrimal glands, ducts, and we have lacrimal sac with nasolacrimal duct and the puncti. Then we'll go to we have lid here, upper lid, and we have lower lid down. At the center we have this one is called cornea. Inside the cornea, this round empty is called pupil. The brownish one is called iris, and the whitish one we call it conjunctiva, and behind it is the sclera. So conjunctiva is the thin layer superiorly. Then we have the sclera and the sclera. We have here the conjunctiva, we have the iris and the pupil inside. This is the structure of the eye. We'll take more details. With this view, we can see here in front we have the cornea. This is the cornea, and we have here chambers called anterior chamber. Behind it we have the iris, and in the center we have the pupil. Behind the iris we have a small chamber called posterior chamber, and this is the lens at the center. Behind the lens we have a large area is called vitreous body. Then we have the retina, the layer, then after choroid, then behind it we have the sclera, the whitish thing is called sclera. So if you can see here, the cornea is continuous with the sclera, and in front of it we have the conjunctiva. We have anterior chamber, we have posterior chamber, and we have also vitreous body. Here, all this area is called vitreous body. Also here another picture. Let's give more details. Again, we have here the first part here is called cornea. anterior chamber, iris, and the pupil at the center. We have the lens, and we have here the vitreous body. Behind the retina, then choroid, then sclera. And here we'll give the optic disc and the optic nerve. Also here we can see layers of the retina first, then we have the next layer is choroid, then after that we have the sclera here. So sclera, choroid, and retina, and in the center we have vitreous body, is vitreous gel. We have here the lens, we have here the irises, anterior chamber, and front we have the cornea. In this picture, we can see the muscles of the eye. We have a lot of muscle that moving the eye and also the lid. You'll take more details about this with pediatric and neuro-ophthalmology lectures. We have superior rectus here. We have the also the lateral rectus. We have inferior oblique, and we have also here the inferior rectus. Also, we have another muscles, and also you can see here the optic nerve, and this is the eyeball. Before we go to the instruments of the ophthalmology, this is a brief information about the anatomy of the eye. If you have any questions, you can ask, please. Okay. Go to the next slide will be about the ophthalmology instrument. Very important when you go to the clinic, you will also you will see these instruments in the ophthalmology clinic. The first instrument is called direct ophthalmoscopy. You can see this is the direct ophthalmoscopy, and I think already in the clinical skill you talk information about the direct ophthalmoscope. Direct ophthalmoscope is used mainly for two functions. The first function is for checking the reflex of the eye. The second function is used for fundus exam. So mainly for two functions, we have the first function is to check the ready reflex of the eye, and also for fundus exam. Regarding the ready reflex, what is the ready reflex? This is the reflex of the it is ready reflex, the normal ready reflex from the pupil when you are putting light in the front of the eye. There is a reflex called ready reflex. It's important in case of pediatric, because if you found another reflex other than red, maybe is indicate there is a eye disease that causing changing in the reflex. Also in adult, in case of like cataract and vitreous hemorrhage and other cases, the reflex also will be changed. So as a screening tool, we can use direct ophthalmoscope to check the red reflex. When you come to the clinic, we'll also practice on how to check the red reflex. Also, the other function is to check the fundus exam. You can also find it in the optic disc also, and in ophthalmology, and also and sometime you find it in the neurology clinic to check the optic disc. So direct ophthalmoscope is called direct because if we have direct, we have indirect ophthalmoscope, but we call it direct because directly when you are putting the instrument in front of the eye, the picture will be direct, which I mean that when you see something in the right side, it is really right side. Indirect ophthalmoscope will take it now. The picture will be verted and inverted, but for the direct, the picture will be right. What's the magnification of the direct ophthalmoscope? Magnification is 15 times. The number of magnification for direct ophthalmoscope is 15 times. Go to the next instrument. This is the indirect ophthalmoscope. So the first one is direct ophthalmoscope. The indirect ophthalmoscope, why we call it indirect? Because of two things. First, if you can see, the indirect ophthalmoscope using lenses. Here we can see lens. That's why it's called indirect. The other thing, because of the lens, the picture is inverted and reverted. But I mean that if you see a finding or lesion in the right side, it's actually in the left side, and if it is in upper, it's actually in the lower. So it is invert and invert the picture of the finding. What is the use of the indirect ophthalmoscope? It's used also for fundus exam. Compared to the direct ophthalmoscope, the magnification is less, is dependent on the lens, but usually between 2 to 3 times. But give me more details, more field, and also more details, and also the peripheries of the retina and fundus. You can see it clearly with the indirect. So indirect give a small field, but the magnification is less, and it is using the lenses. So all clear for the instruments. We'll go to the next instrument, something called phoropter. Phoropter, we find it in all the ophthalmology clinic, and this is the old version of the phoropter. The new version will be electronic, totally electronic, but this phoropter is used for refraction and refinement of refraction. So this instrument is used for refraction. You can see here, this is the eyepieces. The eyes will be here, and they all are lenses that you change it until the refraction will be clear for the patient. Okay, then we'll go to the next instruments called retinoscopy. Retinoscopy, very important to compare it with the direct ophthalmoscope, so will be mixed up. So we have, this is the direct ophthalmoscopy, and here we have the retinoscopy. The retinoscopy is used for refraction. So we have the phoropter used for refraction, also retinoscopy for refraction. Compared between the two instruments, the retinoscopy, this is the retinoscopy, is used for refraction, what's called objective refraction. mainly in children, because in children you cannot depend on the response for their when you ask them about the signs, what is it, you cannot depend on their response. You will use retinoscopy. So retinoscopy is used for refraction, mainly for non-cooperative patients. For cooperative patients, uh, you can use the phoropter for cooperative patients. For non-cooperative patients like uh, children, you will depend on the retinoscopy. So retinoscopy is used for objective refraction compared to phoropter, which is used for subjective refraction. Any questions? طيب. Now we'll go to the next instruments in ophthalmology clinic. This is called slit lamp. Slit lamp is the instrument used for eye examination, general examinations. You can see here, the patient head will be here, and the eyepiece is for the eyes of the doctors. And you will, this is the joystick, will move the instruments to check the eye finding. So this is a slit lamp used for general eye examinations. Every ophthalmology clinic will find this machine. Then we'll go to the lens is called gonioscopy lens. Gonioscopy lens, if you can see, lenses with mirror, sometimes become 3 or 4 mirrors, is used to check the angle of the eye. Angle of the eye is important in case of glaucoma and eye pressure. So gonioscopy lens is used for checking the angle of the eye, and this is important in case of the glaucoma or pressure, to check if it is a close angle or open angle type of glaucoma. Then we'll go to the next instrument. We have this instrument called Goldman applanation tonometry. Tonometry, this word means measurement of the eye pressure. So Goldman applanation tonometry is an instrument used for measurement of the intraocular pressure, intraocular pressures. This is the instrument you can see. This instrument usually is attached to the slit lamp. If you can see in the previous slide, for slit lamp, you can see this is slit lamp, and we have here the Goldman applanation tonometry. It's used for measurement of the intraocular pressure, and usually it is the gold standard and the most accurate way to measure of the intraocular pressure. Again, this is the most accurate or the gold standard for the measurement of the intraocular pressure. We have also other way to measure intraocular pressure. We have this instrument is called tonometry. So as we mentioned, tonometry mean measurement of the intraocular pressure. Tonoben, it is compared to the Goldman applanation tonometry. It is portable. You can. It's not attached to any instrument. You can use it for the patient that you can bring them in the slit lamp, like bedridden patients, and also in case of a trauma or something, you can use it as a tonometry for measurement of the pressure. Then we have this instrument. It's called Hertel exalothermometer. This instrument, you can see it is you can put it in front of the eyes, a measurement of the position of the eye. So Hertel exothermometer, from the name exothermometer, it's measurement of the position of the eye compared to the orbit, and this is important for diagnosis of proptosis. Proptosis is the bulging of the eye. So bulging of the eye is called proptosis, and this instrument is used for measurement of the position of the eye compared to the orbit to diagnose a case called proptosis. Any questions? All clear? Okay. I'll go back a little bit here. Quick review. We have here the diaphragm thermoscope is used mainly for two functions, for fundus exam and to check the red reflex. The magnification is 15 times and give right pictures. Compared to the indirect thermoscopy, it's used lenses mainly for fundus exam, and the magnification is less compared to direct, but the field is larger, and use lenses and give the picture is inverted and everted. Then we have the phoropter used for subjective refraction, compared to the retinoscopy. Here is used for mainly objective refraction. We have here the slit lamp for routine examination of the eye, and we have here the gonioscopy used for the angle, checking the angle of the eye, mainly for diagnosis of glaucoma. We have here also Goldman applanation tonometry is used for measurement of the intraocular pressure, and this is the gold standard. We have here the tonopen is the portable way for measurement of the intraocular pressure. Then we have here the Hertel exothermometer. It is a way for measurement of the and diagnosis of proptosis. Okay. There is a question by Muad. Said objective versus subjective refraction, what's the difference? For subjective refraction is used phoropter. Subjective refraction, that you will depend on the patient response. What I mean that you put the phoropter in front of the patient and you put the Snell chart in front of him, and you'll ask him if you can see this sign or no, if you can see sign or if you cannot see sign. So you are dependent on the patient response for the refraction, and you will change the power and the lenses and the astigmatism of the refraction depend on the patient response. So if you cannot see, you will change the lens to another lens until the patient responds that he see well, then this is the refraction of the patient. For the objective, you will not depend on the patient response. If the patient is child less than 3 years, he cannot tell you about the signs or picture in front of him. So we'll use the retinoscope for refraction, and retinoscope is depend on the lights of the pupil. There's some way he will check the refraction check the fraction without the patient response. This is the difference between the two. Any questions? You can ask about any question that you want for the course in general. Anything you can ask me, please. طيب, we have a question here regarding the quizzes. Usually we'll have two quiz. We'll have it during the course, inshallah. Quizzes is first will give us formations, and also we'll give you some mark regarding the quizzes, and your answer will be in the blackboard. Don't worry, regarding the quizzes, we'll just put the questions and we'll answer it any time that you want. It is not time limited quizzes. You need to answer it within 1 or 2 days. We'll just put the questions or pictures and we'll answer it. طيب, بالنسبة للمحاضرات, there's a questions from Abdullah Jilan. He is asking about which lecture will be included in the midterm. Actually, he regarding these questions, I will inform you that all the lectures from Saturday up to Wednesday, they are included in the midterm. Thursday lectures, which is the retina and uveitis, is not included. So from Sunday up to Wednesday, lectures are involved or included in the midterm exam. We remove the Thursday lectures to be more easier for you. But all other lectures from Sunday up to Wednesday will be included in the midterm exam. Midterm exam will be MCQs, and also we will put spot diagnosis exam. Spot diagnosis is we'll put a picture for you, one picture, and we'll put the diagnosis directly without any details, no questions, just spot diagnosis, or just 1 word or 2 words regarding the diagnosis of this picture. We will have 10 slides, 10 spot diagnosis. Also, in OSCE, we'll have usually 10 slides for OSCE or OSPI exam. But for the final exam, the OSCE will have questions and sometimes scenarios with the picture, and also questions you will answer. We'll answer it with the slides. But for spot diagnosis, no, just for diagnosis only. Any other questions? Spot diagnosis without any scenario, just a picture, and you'll put the diagnosis for it directly. For Saif Shambari, he asked about the marks distribution. Already, we talked about this in the first slides of the lecture, but in general, we'll have 30% of the marks will be in the midterm exam. We have 10% continuous evaluation, which include quizzes, attendance, and also spot diagnosis for midterm. Then we'll have 60% for the final exam, 30% for the MCQs, and 30% will be the OSCE exam. This is the distributions for the marks in short. Any other questions? For the attendance, أرجو من عبد العزيز leaders عبد العزيز and Rabab to talk the attendance. We have here 57 attendance, 57. I mean 56. We have 56 students. So please Abdul Aziz and Rabab to take the attendance. Here is my email. If you have any questions, any concern, you can just send me an email, please.